Welcome back. We'll take a look at our endocrine hormones now and take a little bit of a quick review here into some of the things that you've seen probably in anatomy. And so one of the biggest components to our hormones is the pituitary gland and its component with that are there for the hypothalamus itself. And so the hypothalamus is going to work in conjunction with the pituitary gland, sending both nervous signals as well as hormones down to the pituitary gland. Pituitary gland kind of hangs off of the brain there, coming down from the diencephalon and the hypothalamus. It has two components, the anterior and the posterior. The anterior being a true endocrine structure in terms of that it produces its own hormones, and the posterior pituitary there just saving the hormones, in a sense, storing them there from the hypothalamus. And so we'll take a look here. The posterior pituitary gland grew down from the hypothalamus, and so the hormones themselves that we have here are antidiuretic hormone, or ADH, and our oxytocin are produced up there in the hypothalamus, and then they are sent down to the posterior pituitary to be stored there. And then when needed, the posterior pituitary gland is then going to send nervous signals down here to the posterior pituitary gland, and we're going to get the release of those hormones. Antidiuretic hormone we talked about back when we talked about the kidneys and their function there in terms of conserving water. Oxytocin is going to go to the mammary glands and the uterus, and this is going to cause a contraction in the glands themselves, or in the tissues themselves, both in the mammary glands and the uterus, to allow for childbirth and or milk production and milk letdown there. The hormones themselves that we're going to run through are all available on the chart in the classroom. And you can see that chart, and you need to know essentially what hormone is produced, where it's produced, and then where is its target, what's its function for them. And you can find that in the classroom. The anterior pituitary gland has a large amount of hormones produced there, and these hormones are actually synthesized there. They're produced in the anterior pituitary gland, and then released in response to another hormone that tells them to be released. And so typically here what we have is a releasing hormone that's going to tell the hormones that they need to be secreted, and then they're going to have an inhibiting hormone that's then going to stop them. And so these are going to be stimulated by a hormone both on the positive side as well as the negative side. Several of the hormones that we have here are what we referred to as tropic hormones, and so these are going to go and stimulate another endocrine gland. Excuse me. And so they're going to go down to the next level, in a sense, and stimulate the next endocrine gland in the process itself. And those are going to be our thyroid stimulating hormone, our adrenocorticotropic hormone, or ACTH, our follicle stimulating hormone, and our luteinizing hormone. So those are all going to go down to another endocrine gland, and then that endocrine gland is going to be stimulated to release its product in relationship to that release of those hormones there. Growth hormone and prolactin are both going to go down to target tissues, and we'll take a look at those right now. So we have some different hormones here from the pituitary gland. We have our posterior pituitary, which gave us our ADH and oxytocin. And then the anterior pituitary gland, we get a whole host of different hormones. Thyroid stimulating hormone goes down to the thyroid, stimulates its release of thyroid hormone. Prolactin goes down to the mammary glands and stimulates the production of milk. Our FSH and LH are going to be present in both males and females, and so although we think about them as being, in a sense, kind of a primarily female type of a hormone, they are active in both males and females, and they're going to stimulate the production of the hormones as well as the production of the gametes. And so this is going to allow for gamete production as well as the hormone production there as well. Growth hormone basically stimulates just about every cell in the body in a sense, and so this is going to go out there. But one of its bigger components in terms of where it stimulates is especially bone and muscle growth. And so those two are the biggies in a sense as far as their production that's there, and is going to allow for the growth of a person, especially early on up until puberty. Adrenocorticotropic hormone, or ACTH. This one's again going to go down to the adrenal gland, and this is going to stimulate our hormones of the cortex and get us our cortical hormones that are there in our different kinds. So all of our corticosteroids that are there, our mineralocorticoids, our corticosteroids, our glucocorticoids, and the gonadocorticoids, all being produced in response to ACTH. So you need to know what the hormone is, where its target is, and then what it stimulates as far as the output goes. And so for TSH, we have our thyroid stimulating hormone. This is going to go down and stimulate the thyroid gland. The thyroid gland is then going to start to produce its two hormones, our T3 and our T4, our thyroid hormones. And then that's going to allow for an increase in metabolic rate. So our metabolism is going to go up. Adrenocorticotropic hormone goes down to the adrenal cortex. And its primary thing that it's going to produce is cortisol. And cortisol is going to be all about getting us energy. And so it's metabolic as far as the output goes. And this is going to be in response to stress. And so in times of stress, we're going to need things like increased glucose. And so this is going to get us that energy that we need at that time. Prolactin goes down to the mammary glands. So after pregnancy, towards the latter end of pregnancy, prolactin levels are going to start to increase and then continue as lactation occurs. And that's going to stimulate the mammary glands in their milk production and growth. Next up, we have growth hormone. Growth hormone, as we said, goes to basically all of the tissues in the body. This is going to increase the metabolism of those cells, and so it's going to increase our ability to grow and increase their overall metabolism for things. And then it's also going to go to the liver, and it's going to produce a series of compounds called somatomedins, and this is going to lead to our bone growth and then our muscle growth. And so this is the overall growth of the tissues and the cells and things like that that are there. Luteinizing hormone and follicle stimulating hormone are LH and FSH. We have both of them being released. They're going to do essentially kind of the same thing in both the male and the female. When it comes to follicle stimulating hormone, we think about the gametes. And so this is either going to be producing the oocytes or sperm cells in males. And then luteinizing hormone, we think about the hormones of the sex hormones. And so we have our estrogen, progesterone in females, we have testosterone in males. And so especially in females, luteinizing hormone and FSH are going to change kind of in their output. In males in general, luteinizing hormone and follicle stimulating hormone are going to stay relatively level as far as those go. We'll talk about those more when we get into reproduction. So our hormones oftentimes run on a feedback loop, and so they're going to use negative feedback to allow for us to control when they're being released and when they're not being released. And so as with thyroid hormone here, as thyroid levels increase, that's going to lead to a decrease in secretion from the anterior pituitary. And so the anterior pituitary is going to be inhibited in its release of TSH. And then TSH, as that decreases, that leads to a decrease in thyroid output of thyroid hormone. As that then, in a sense, changes as we go in the opposite direction there. So if we have a decrease in thyroid hormone, that's going to lead to an increase in the anterior pituitary's stimulation, and that's going to lead to an increase in TSH release, which then leads to an increase in thyroid gland production, which then gets us back to an increase in thyroid hormone. And it just goes around and around and around, depending upon how much thyroid hormone has been released there. So thyroid hormone itself is important as a metabolic stimulator. And so this is going to increase our metabolic rate in essentially most tissues of the body itself. Certain places, if we have too much of our thyroid hormone, we're going to see effects on it, things like the heart, as far as the heart rate goes, so it's going to increase that as well. Thyroid hormone also increases the body's responsiveness to epinephrine and norepinephrine. So it's going to be able to allow us to get into that fight or flight mode, in a sense, a little bit better as well. Thyroid hormone is absolutely essential for normal growth and development, especially during the reproductive phase for the fetus. And so if mom has a low thyroid hormone, the thyroid hormone can cross the placenta, and so it's going to lead to the fetal thyroid hormone becoming low as well. And so this can start to lead to issues as far as normal development during the fetal period, and we're going to have problems from that point on. And then all through life, it's going to cause the potential decrease in overall body production and body function if we have a low or hypothyroid situation. Hyperthyroid is just going to turn everything up. And so we're going to see those changes there within them as well. Cortisol is released in response to our adrenocorticotropic hormone being released. And this is a process where whenever we have stress on the body, that stress essentially comes to the hypothalamus. And so the hypothalamus recognizes that we have a stressful event, whether that's sickness or whether it's mental health. All kinds of different things can lead to that body stress. That causes our hypothalamus to release our CRH, or our corticotropin releasing hormone, which then is going to get us our adrenocorticotropic hormone, or corticotropin. And that then goes down to the adrenal cortex, and we get the release of cortisol. Once cortisol is out there, this is going to essentially fuel our body for that stressful time. And so cortisol levels are going to lead to an increase in blood glucose. So it's going to start to break down things that are going to allow us to increase the amount of glucose that's in the blood. So we're going to go through gluconeogenesis. We're going to change things like amino acids and fatty acids into glucose. And so we're going to go through that process to ultimately increase the total glucose levels of the body. And so we're going to increase those amounts there in any means possible. Cortisol levels also fluctuate throughout the course of the day. And so not only do we use them during times of stress, to where we have an increased amount there. So when we have increased body stress, we have the potential to increase that cortisol level. If we don't increase the activity of the body during those times of stress, and so if we just simply release cortisol and allow for an increased amount of glucose to be out there, if we don't use it, then we potentially store it away again later as fat. And so this is where stressful times can potentially lead to weight gain and things like that as well. From there, though, we have this kind of altering amount of cortisol levels throughout the course of the day. They go along with our diurnal cycle for the body. So this is part of our normal fluctuations throughout the day itself. Cortisol levels are essentially highest at the point when we wake up. And so in terms of the times when we wake up, we have the greatest amount of cortisol. It kind of gets us ready for the day in a sense, gives us a boost of glucose to kind of start our day. And so we have energy to get up, get going, and start the day with enough energy to get our body going. We've been in a low metabolic state, in a sense, for the course of our sleep, and now we need those levels to come back up. And so we need to boost our energy and get our energy going for the day. So with that, our body is essentially primed and ready. A lot of people don't necessarily feel hungry as soon as they wake up, and part of that can be because they've just dumped a whole bunch of glucose out into the body, out into the bloodstream, into the plasma, and now we have enough energy to get us along for some time into the day itself. But those levels will start to fall off, and we will need some more energy an hour or two after we have woken up for the day. If we alter our morning and night times, as far as moving to different time zones, working swing shift, things like that, as far as our body's sleep and cycles go, and that can then start to alter this cortisol levels. And so this can start to mess with things, along with our melatonin levels, which are fluctuating throughout the day as well. This is where we start to get jet lag and things like that, or those that are on swing shifts where they're working days and nights, their sleep cycle can oftentimes be, and their energy levels and things like that can oftentimes be disrupted simply because of disrupting their normal hormone productions. Next up, we have the pancreas. And so we have insulin and glucagon productions. Insulin and glucagon productions occur at different times. Insulin is going to be released when we have an increase in plasma glucose levels, and glucagon is going to be released when we have decreased glucose levels. And so after a meal, our insulin levels are going to go up in terms of their production. So our beta cells are going to be starting to release insulin. This is going to allow for the uptake of glucose from the plasma, start to release those blood glucose levels. And so for the next, depending upon the size of the meal, depending upon what's in it, we talked about this for digestion, is going to dictate kind of when we get the need for another meal. But typically, in the sense, for about 4 hours or so, we have our glucose levels kind of falling over that period of time, and then glucagon levels are going to start to rise. And so insulin levels will go down, our alpha cells will start to produce more glucagon, and we'll start to get the release of glycogen from the liver again, and allow for us to increase our glucose levels back in the blood once again, sustain us until we can get to that next meal. So this is essentially another negative feedback loop where we have the production of either glucagon or insulin, depending upon which way our glucose levels are going in the blood. So after a meal, so we've just eaten, we have blood glucose levels rising. This is going to cause a positive effect on those beta cells and a negative effect on the alpha cells. And so our insulin production is going to go up, our glucagon levels are going to go down, and that insulin is then going to stimulate our cells in our body to start to take that glucose out of the blood, start to store it away, get it into the cells. After a period of time goes by, after we have, in a sense, been fasting, our blood glucose levels are now falling, and that's now going to increase the stimulation to our alpha cells. We're going to get an increase in glucagon, and we're going to inhibit those beta cells. And those beta cells are then going to decrease the insulin production. Blood glucose levels are going to start to rise once again. So we're going to pull those levels back up. And so we have kind of a situation where blood glucose levels have risen, and then they've started to fall, and we start to bring them back up again with that glucagon. All the time kind of trying to maintain a level somewhere in the middle, in a sense. And so depending upon where we are on the side of a meal is going to dictate when and where we get either glucagon or insulin. When we're unable to control those levels of glucose within the blood, This is generally going to be because of a lack of our ability to utilize insulin. But this comes in kind of two different varieties as far as the major types of diabetes. And so what we typically think of as diabetes is typically diabetes mellitus. And with this, we have either type 1 or type 2. In type 1 diabetes, oftentimes this is seen as an autoimmune disorder, and it decreases or destroys the function of our beta cells. And so those beta cells are essentially destroyed. So the amount of insulin that's being produced is typically none, or just a very, very small amount that does not have any kind of consequence in terms of the amount of glucose that can be taken up. Usually we see this in a start as a childhood disorder, and so it begins early on in life, and it's going to require the administration of insulin. In the past, this was always as insulin injections, but now there are all kinds of insulin pumps that can be utilized as well to help to monitor and control insulin levels throughout the day without having to constantly check and monitor what the glucose levels themselves are. With type 2 diabetes, this typically occurs later in life in adulthood. And with this becomes a process oftentimes of a person's weight. And so essentially their body weight has become an issue. They have an increased amount of adipose. They have an increased amount of blood glucose in their body over time. And usually their insulin levels themselves are usually pretty normal. They may even be producing more than what they typically would see. The problem is that the bodies in the body, or the cells in the rest of the body, have become insensitive. And so the sensitivity of all of our target cells to insulin has become reduced. And with that, that means that no matter how much insulin we have out there, essentially, we've had a downregulation in the receptors, and so the cells just don't listen to the amount of insulin that's there. And so even though insulin levels, in a sense, are normal or even elevated, our body basically doesn't listen. And so our cells are no longer listening to the signal to take that glucose up out of the bloodstream and utilize it. We have what we call insulin resistance. This can be controlled oftentimes by just simply weight loss. And so reduce the amount of weight that the person has, get them to do exercise, so start to utilize the glucose that is in their bloodstream. That, along with some dietary changes, which is going to help with the weight loss, that can lead to oftentimes a reversal of this disease. And so we can start to turn things around, get the person to not need things like hypoglycemic drugs. And so that can kind of change things for them. In this case, they don't need insulin, at least at this point early on in the disease, but sometimes they will require it later on as the disease progresses. So they may become an insulin-dependent type 2 diabetic as well over time. And that's it for the endocrine system. We'll see you next time.